The issues affecting you. Revealed, explained, discussed. Now on WGAL 8 in Focus.
Hello, I'm Susan Shapiro. About 1 in 8 men will be diagnosed with prostate cancer in their lifetime. The American Cancer Society says it's the second leading cause of cancer death in men in the U.S. Some Pennsylvania lawmakers want to make sure insurance covers all costs for screening for eligible men in the Commonwealth each year.
We're trying to make sure that they have free cancer screenings in Pennsylvania.
Today, we'll talk with a prostate cancer survivor about his journey and a cancer specialist about the importance of screening and the resources available. We're putting prostate cancer in focus. I'm joined now by Dr. Ed Balaban, the Vice President of the Pennsylvania Medical Society and an oncologist, a cancer specialist.
Yes.
Thanks for being here.
Thank you for having me.
Why is the prostate susceptible to cancer?
So the prostate, like every organ, has a high turnover rate cellular-wise. And so like breast and the ovary and so on and so forth, it might be considered to be more prone to mutations and such that cause cancer. But bottom line is, it's an organ.
Are there certain men who are at higher risk for prostate cancer?
There are 3 groups in general. One is first-degree relative. You have family history of prostate cancer. First degree is a father or a brother, for instance. If you're black or African ancestry, it's another high-risk group. And a third group that has evolved in the past several years is having a known genetic mutation that might predispose to cancer.
Like the BRCA gene or similar
like the
genes?
BRCA gene, that's the one that everybody seems to know about, our BRCA gene, and there's a whole family of ATMs and so on and so forth, and that go on and on.
There seems to be a lot of question about screening. In 2012, the U.S. Preventive Services Task Force recommended against routine screening for men. Was that a good idea, and has that changed things?
I think it has to change, and the task force, I understand, knows that. They're reconstructing their their recommendations. We'll see what happens there. But their data did not include, because, and they acknowledged this, they didn't have enough data for younger folks. They didn't have any really good data for the black population. And there wasn't a genetic mutation family around. So that has to now be considered.
Do you think that cause and effect? There have been studies showing there's been an increase in advanced prostate cancer being diagnosed. Do you think that's a cause of that? I
think it contributed to it. How about that? Because of the shared decision-making, or rather open-ended guidelines that they offered, physicians like myself adopted those. And so now, in retrospect, as we see more and more of what you said, maybe that wasn't such a bright idea.
Who at this point should be screened and how?
So I still believe that folks, as the guidelines date back 55 to 69 years of age, should have a discussion with their physician. But the folks that need to get on the screening on a very regular basis is those that I just mentioned, of family history, those that have a family history or a genetic mutation in their family, or black or African ancestry.
And that's with the PSA and also a digital rectal exam.
Those are the 2 tools we have.
An elevated PSA can also mean other things, can it?
Yeah, so like with every biomarker in cancer care, there's problems. And this always comes up in conversation. There's sensitivity and specificity. Some of our biomarkers are very specific, but they miss the earlier cancers. PSAs, they're very sensitive. They're sensitive to, but they're not specific. But as you said, so the PSA, if you have an elevated PSA, it could be an inflammation of the prostate. It could be a benign prostatic BPH, that sort of thing. It could be related to drugs you take. So there's a lot of other reasons for an elevated PSA, yes. But having said that, it starts a conversation. And the urologist, a physician, starts to repeat the PSA, maybe at close time intervals, to understand whether this is a problem or not.
Because some have argued that it leads to unnecessary biopsies and other kinds of,
That's been the big criticism.
Things.
But again, if there is a targeted group of a population that I just mentioned, and you have a PSA and it's repeated and it's still elevated PSA, those numbers, those side effects that you just mentioned, the overtreatment, the overdiagnosis, they start to drift down as far as the frequency goes.
Just quickly, what are some of the symptoms that someone might,
Boy, that's the toughest
aware
question
of?
of all, because frankly, by the time you have symptoms, it's really too late. The symptoms might be urination, or frequency of urination, but that's a very frequent issue as we grow older. Once you start getting other symptoms like severe urinary incontinence or pain, then and the pain is pelvic or bone, then it's a real problem.
Hence the reason for the screening, and
Yeah,
we'll
that's
talk
right.
more about that and legislation that could increase access to screening in Pennsylvania.
This is WGAL 8 in Focus, coverage you can count on.
We continue our conversation with Dr. Edward Balaban, who's the Vice President of the Pennsylvania Medical Society and an oncologist. Thanks again for being here. There are a couple of bills that are making their way through the state legislature. What would they
Right.
do in terms of prostate cancer?
So, as we talked about, the bills are asking for payment to get rid of cost sharing or deductibles, co-payment, whatever, for the PSA, targeting again the high-risk population, as we mentioned before, the first-degree relatives, a genetic mutation in a black population. Those are very short simplification. That is it. Let's get those paid for.
This would be paid for by the state?
Yes, at 40, or insurance companies, which is and now that's where these bills are at the insurance committee. Right.
Is this something the insurance industry is pushing back against? Or?
Yes, undoubtedly. And as I've come to learn as I get more and more involved with health policy, this is not the first rodeo for this notion, these bills, but it becomes more and more critical, as we already mentioned, as more advanced disease and more deaths are occurring. If these bills are passed, the screening will go up 25%. The risk of prevent metastatic disease, of finding a metastatic disease, over 500 or 600 patients, 160 lives are predicted to be saved with these, as well as, if you were looking at dollars, over $180 million is saved if the PSA and the screening is in place, rather than having to deal with or face with the finances and the personal issues with treatment of metastatic disease. So, but insurance companies, yes, are pushing back.
Yeah, understandably, I guess, as they have done with other things like mammograms.
Like mammograms. But we should note that there are at least 10 or 12 states now that have this kind of bill in place. They're all around us. Tennessee, Maryland, New Jersey has one, Delaware has one. So we're not making this up. I mean, this is not
Right.
precedent setting. Yeah.
You're not making new ground here. In terms of treatment, once someone is diagnosed with prostate cancer, what are the options?
So
I know there are a lot of them.
Sure, depending on age and comorbidity issues and so on and so forth. The treatment is so broad. Everything from active surveillance, just watching.
Right, we heard a lot about watch and wait.
Right,
Yeah.
watch and wait, to total prostatectomy, removing the prostate altogether, in-depth radiation therapy, and everything in between. So it is not a one-size-fits-all, either with the testing or the treatment. So in between that is the combination of hormonal therapy, anti-androgen therapy, if you will, for prostate carcinoma. And if the disease gets more advanced, then we turn to biologic agents, immune checkpoint inhibitors, and traditional chemotherapies in addition.
We've heard with the removal of the prostate, there can be side effects like incontinence and impotence. Is that still the case, or
still an issue. It's
has
less
it gotten
and less.
better?
It's less and less. No, I'm not a surgeon, and my surgical friends tell me that the incidence of that is decreasing as the techniques become better and better. But there's no doubt that yes, that's a conversation that will have to take place, whether it's erectile dysfunction or urinary incontinence or bowel issues with all the treatments. Those are the three major things that the discussion goes on.
Obviously, with any surgery, there's a risk. Have some of the other treatments, the hormonal treatments, gotten better?
They've gotten better. In addition, the understanding of not just the agents themselves, but the timing of the agents and how long and so on and so forth. We've got a long ways to go, but certainly compared to what it was 15 or 20 years ago, a lot smarter with how to deal with prostate cancer.
All right, well, stay with us. Coming up on WGAL 8 in Focus, we'll hear from a prostate cancer survivor who's also the chairman of the Pennsylvania Prostate Cancer Coalition.
This is WGAL 8 in Focus, coverage you can count on.
I'm joined now by retired Colonel Jim Williams, a prostate cancer survivor and the chairman of the Pennsylvania Prostate Cancer Coalition. Thanks for being here.
Thanks for inviting us.
Jim, how were you diagnosed and when did that happen?
I'm a 34-year prostate cancer survivor. I retired from the military and was working in the Chicago area and working at the American Bar Association as a human resources director. My wife said that, you haven't gone and seen our family physician. And as a typical man, I said, well, I'm feeling good. There's no necessity for that. I was an active private pilot at that time, getting my flight physical every 3 years to maintain my license, running 5Ks. Why do I need to go see the doctor? Well, she said he's a young, good internist. The family's going, so you need to go. So reluctantly, I went to the doctor. He introduced, this is 1991, he introduced this new blood test called PSA. There was no conversation with me about it. He just incorporated with the blood work. Well, the number came out high for PSA. At that time, the magic number was 4. My number was 10. I was African American, so I was referred to a urologist. Here again, I was blessed because I had a urologist who did a biopsy, found the cancer, had a Gleason score of 7 on a scale of 1 to 10, and I learned that I needed to do something. I had cancer. He said to me, I want you to do some study of what treatments are available before we go further. And this is 1991, before the internet. We had to go to the library and read books. He said, I want you to also talk to oncologists because they deal with all kinds of cancers. I want you to talk to radiologists because he or she sees the world differently than I do. And I want you to go to Mayo Clinic because they're doing a lot of work on radical prostatectomy. I said, what's that about? Surgery. Now I'm living and working in Chicago. Chicago is a major U.S. city. It has outstanding health and physical and clinical activity there. Why Mayo Clinic, which is 5 hours away in Rochester, Minnesota? He said, because they're concentrating on surgery, and I think you need to go up there to get a second opinion. So I took that educational journey, seeing the other specialists, and ended up at Mayo Clinic.
And what did you have done?
Well, I had surgery done at Mayo Clinic. I fell in love with Mayo Clinic, and Susan, I knew I was at the right place because 2 doors down from me in the hospital was a sheik from the Middle East.
Wow.
Who had his private 747 parked at Rochester, Minnesota airport.
So you had a prostatectomy.
And I had a prostatectomy.
And how has that gone for you all these years?
I'm 34 years cancer-free. But not only did I have the surgery, Mayo Clinic suggested that I also have hormonotherapy because there might have been some microscopic cancer that they didn't see. So the results of those 2 procedures have left me cancer-free for 34 years. And in addition to that, being retired military, I had a health care plan, which is called TRICARE for Life, that paid for all these costs. So I had a perfect journey on my cancer journey. And I found that I'm the exception, not the rule. I thought my journey was the standard in America, and I found out it wasn't, and that's why I got involved with advocacy.
And founding and helping to found the
Yes.
Pennsylvania Prostate Cancer
Yeah,
Coalition.
right.
Why is it that a lot of men don't like talking about this and don't think they need to talk about it or do something about it?
We men have hard times really talking to each other about personal matters. We'll talk about females. We'll talk about, we saw Susan on TV. We'll talk about sports. But things are really close to us. We have difficult expressing those things. And women and their mentors have a relationship with the health profession. As they grow older, they understand the importance of annual physical examinations, inspection of the body. We men don't teach or have that same mentoring with our elders. And so there's a gap. And the only time we go to the doctor is when we're sick. We pride ourselves in not going to the doctor, not missing a day of work, etc. And in today's environment, we need to understand that you need to go to the doctor when you're well, not when you're sick. I asked men who take their cars in frequently to get the oil change, was the car sick? I mean, why do you do that? Well, they understand preventive maintenance, but they need the same party to preventive health.
All right, well, stay with us, Jim. We'll talk more about the coalition and the resources that are available to men.
This is WGAL 8 in Focus, coverage you can count on.
We're wrapping up our conversation with retired Colonel Jim Williams and Dr. Ed Balaban. Thanks so much again for being here. We appreciate it. I was reading 13,400 Pennsylvanians will be diagnosed this year alone with prostate cancer, and 1,480 will die of the disease. Those
right.
are some big numbers.
How about that? But think about it nationally, the number goes up logarithmically. In the United States, it's going to be next year 340,000 diagnosed and about 35,000 deaths. As I started earlier and said, it is the leading cancer, second leading cancer in men after skin cancer.
And Jim, I imagine it's a pretty scary diagnosis to get when they tell you have cancer and it's prostate cancer.
It is. As I stated previously, I never felt better in my life. My wife saved my life by insisting that I go to the doctor. And then after getting a diagnosis of cancer, how can I be so sick and feel so well? And it's not understanding the disease, that the best time to treat it is in the early stages, and the early stages is before there's any symptoms, and that's why the screening tools are so important.
A lot of men might be walking around right now with prostate cancer and not know it.
No question about it.
What would you say to men who are out there listening, of any age, I guess? What should they be aware of?
Don't fear the finger. As the doctor mentioned, one of the screening tools is the digital rectal examination. And I tell men, ask your wife the examination they go through every year. And we are asking you with the digital rectal examination to have a 10-second test that cannot determine whether you have cancer or not, but can determine the health of the prostate. For some reason, all men's prostates enlarge. We don't know why, but the symptoms that causes enlargement also are the symptoms for prostate cancer. So it's important. Men should be as sensitive to their prostate as women are to their breasts. But because we men don't advocate for our health, we don't have the priority in the medical circles as women do. My counterpart, Pat Halpin, who's a chairwoman of the Pennsylvania Breast Cancer Coalition, does a tremendous job in rallying women around breast cancer. This month is Prostate Cancer Awareness Month. See very few people wearing the blue ribbon. On October 1st, Pat will have 100 women at the Capitol, and the fountain will automatically turn pink. And so a lot of health policy is not determined based on science, it's based on advocacy.
Yeah, and it's not getting the kind of attention as breast cancer awareness does, is it, Doctor?
It just hasn't. And Jim said it so well. I don't know where to place the blame, but I think a lot of it has to do with the male feelings and sentiments about all that. But it has also to do with our guidelines and such, catching up and teaching physicians who teach patients it's time to get checked.
What kinds of resources are out there from the coalition for men who may get diagnosed?
Well, you know, knowledge is power. And so we try to go to many events, and you have to go where they are. We go to baseball games, we go to hockey matches, we go to Friday night happy hours, trying to pass out literature and trying to make men aware of the benefits of screening. However, our best audience for men's health is not men, but our females. They understand the importance of having a continual liaison with their physician and the health community. And we're trying to get that same message over to men. I'm 89 years old,
Wow.
okay? I was diagnosed 34 years ago. And what's devastating to me is you see men work hard, save their money, and retire, and then die. They don't get a good return on their life investment. And so taking care of their body is just as important as taking care of their car so they can get a return on their life's endeavors.
I'm sure you would
Absolutely.
second that.
I would certainly. Yep, you bet.
All right. Thank you both for being here. We appreciate it.
Thank you for having
Thank you
us,
for having
really.
us.
We contacted the Insurance Federation of Pennsylvania for a comment on the legislation currently going through the State House and Senate. We did not hear back by our production deadline. If you'd like to learn more about the Pennsylvania Prostate Cancer Coalition and the resources available, visit paprostatecancer.org. Thank you for joining us for WGAL 8 in Focus. For all of us at WGAL, I'm Susan Shapiro. Join us again next Sunday morning at 11 o'clock for WGAL 8 in Focus, right after NBC's Meet the Press. And you can watch every episode of In Focus, plus WGAL's latest newscasts, original programming, and more. Just download the Very Local app and stream for free on Roku and Amazon Fire TV.